committee here and take up the first bill 173. You have a copy of 173? Yeah. I thought I had my bills all in a nice order here, but I guess I don't. I just, this is, okay. All right. I don't need it anymore. Okay, there's no problem with 173, right? Yeah, I'm looking at the insurance department. This is an insurance department request. Okay, we're all good. Okay. All right. So one of the things we're gonna do here is not only take have a subcommittee, but I'm going to need who's going to make the motion. So when we exec this bill, I know ahead of time who's going to make it. So who would like to make the motion about to pass on 173? Carrie, perfect. Okay. Correct. And we all know how important it is to get those blurbs done on time. Yes, you do. That's why I said it was perfect. Okay. Representative Carey, second by Representative Burrows, moves ought to pass on 173. Is there any discussion on the motion of ought to pass? Okay. All right. Actually, we make sure who I have the people for this
Yeah, here.
subcommittee. So we have. Okay.
Anita, who am I subbing for?
Oh yeah. So we have McGue, Purcelli, Hunt, Gibbs.
I'm Gibbs. Hey, we're both short.
And I was going to say something else about age, but that's fine.
Oh, watch it. Just watch it.
Withdraw that.
By the way, it's Representative Spear, not Representative Carey.
Oh, I don't care.
Just for the record.
Oh.
Go on, go on.
Okay. Okay. And Burrows and Rafter. Okay. All right. All right. So Representative Carey, second by Representative Burrows.
It's Representative Spear.
Spear. Oh my God. I'm sorry.
For the record, folks.
Now I know what you're talking about. And I always spell it wrong. I before E except after C. Okay. Any discussion on the motion? Seeing none. All those in favor, please raise your hand. 1, 2, 3, 4, 5, 6. Okay. Oh, they changed this. Okay. Okay. On to the next one. Relative to insurance coverage for pelvic floor therapy. Okay, so if I understand this one correctly, the department has already generated a report to analysis on this, and that so that's going to occur going forward, and that at this point we really don't need this commission or whatever this is.
Yes.
And that what we really would like to do is just interim study this bill so that in September you can give us an update on where you guys are.
We already did the report and
Yep.
already provided it to you and the Senate Health Committee. So the work's done. There's nothing more to do. We
Oh,
did
there's
not
nothing to report?
identify.
Nothing.
We didn't identify anything. So-
Okay.
Excuse me, did we get a copy of the report?
Yes, it got filed and I believe emailed, but I can provide another one.
It's all right.
Oh,
Right.
it's
It,
We'll
Yeah.
provide it again.
Filed means you sent it to me? No, who
Yeah,
did
I
you send it to?
It was emailed to the whole committee.
It was. Okay. We got
I
a lot of
believe during
emails.
when the hearing was happening, it happened right then.
Right
So,
then and
during
there.
the hearing
During the hearing.
or immediately after. So
Okay. All right, so we don't even need even to hold on to this bill. It's all said and done.
it's all set.
You want? No, I want to kill it. I think they're just telling us to go ahead and kill it. You know, I don't know unless you feel differently about that. But... Okay. Look at Representative Hunt, seconded by Representative Burrows. Moves in expedient to legislate. Any discussion on the question? All those in favor, please raise your hand. 1, 2, 3, 4, 5, 6. Okay. Okay. Alrighty. Let me just make sure. Okay, so that was 177. Okay, on to the next one. Relative to health insurance coverage for prosthetics for children under 19 years of age. Who? Okay, Representative Burrows. To pass. Second by Representative Hunt. Any discussion on the motion? Okay. All those in favor, raise your hand. 1, 2, 3, 4, 5, 6. Beautiful. Okay, relative to third-party liability in Medicaid. Okay, bill number 312. Okay. Who would like to make the blurb? All right, blurb. Representative McHugh. Second by Representative Burrows. All right, and ought to pass. Any discussion on the motion? Seeing none, all those in favor, please raise your hand. 1, 2, 3, 4, 5, 6.
312.
312 was Representative McHugh. Second by Representative Burrows.
Thank you. 353.
Okay, all right. Yes. Okay. All right, relative insurance coverage for autism spectrum disorder and Down syndrome. I think this bill has got some issues. And I think we should interim study it.
Can you describe any of the issues?
Yeah, well, the fact that we heard from that one section needed to be, that they were repealing the wrong paragraph, notwithstanding that we could fix that, but the part about how this new therapy that's being used is actually, it's not even accepted by Medicare anyways, and who you would think would cover it, you know. No, Medicare and Medicaid, both.
Oh, okay, I guess
Yeah,
young people
yeah.
could be on
That
Medicare.
keep Medicare is, obviously fed. Medicaid is the state's got skin in it. But that in terms of this, the application of this therapy and how this therapy is supposed to work, okay, it has not really gone through the full, testing that you normally do in a medical procedure, what a process. And so, in terms of until we need to know that these practices are generally accepted, that I think it's premature to pass this legislation.
Do you know how widely used it is?
I don't. I mean, in terms of no, I don't know that it's how widely used. And I don't know, if anybody can tell us how widely used this procedure, Well, it was called. That name for it, but it was a name. Yeah. Right. Right. Is anybody here to speak for this bill or for that issue? Okay. So that's what I'm just saying, that it might come. I mean, I am I'm gonna have to say, being on this committee and doing mandates all these years, the DSM is I know is the Bible, and the DSM in terms of it's gone as far as defining it, but they have not. There's no generally accepted procedures and process, and so I just think it's premature for us to be passing this legislation. Any other comments from anybody? Okay, Representative Hunt, second by Representative Burrows. Interim study. Any discussion on the motion? Seeing none, all those in favor, please raise your hand. 1, 2, 3, 4, 5. Those opposed? Okay. Okay. Yes, I made the motion. So it was 353. Okay. All right, next is 399, relative insurance coverage for blood testing associated with elevated lead levels. Okay. So who would like to make the motion? Burrows? Seconded by Hunt. Any discussion on ought to pass? Okay. All those in favor, raise your hand. 1, 2, 3, 4, 5, 6. Okay. All right, next is 556, prohibiting health carrier firms from establishing payment or reimbursement provisions based solely on the participating provider's licensure. So, obviously, this bill is rather benign because there's so many other factors in how they determine how the compensation is. But when I kept saying to myself, solely. So
You kind of laughed at me when I said it.
no, your question was legitimate because you're like, where did this come from, and how does this got to do with insurance? That was really legitimate. I was laughing because I had so much history, when
Yeah.
it comes to the credit bureaus, the credit bureau for driver's auto insurance. But this week, my my family practice, which is actually owned by the hospital, called me up and said, "Well, your physician, who was your primary, has just left. He's going, going across the street and starting private practice, and so you have this appointment for your annual physical, and so we need to have another person for you." And I said, "Okay, so who do you got?" And there was two nurse practitioners, and one of them I had before, so I knew them without identifying the sex, and then that the other one was also a nurse practitioner, and I said, "So you don't have any MDs or DOs or anything?" And they go, "Well, no, we don't." And so then I was thinking about this bill, and I says, obviously it's just the solely is just it just solely, but the two problems I have, one is a precedent that if we did this, how many other practices are going to come in and say we are just like them, and we have to go through this every time. A and B, is this a disincentive for the hospital of the family medicine to actually go find a doctor if they can get a nurse practitioner rather than a doctor? That was my concern, Representative Burrows.
To the last point, I would say that it's just a reality, particularly in our hospitals in the northern part of the state. We can't find doctors. So when we don't have doctors, we rely on nurse practitioners. And,
Right.
and I understand that you might want a physician rather than a nurse practitioner, but they are qualified to do a physical. It's obviously it's your choice if you don't choose to do that. But I think a lot of hospitals and practices would struggle if we limited it to doctors. So I think they should be compensated the same.
Well, I think we're not necessarily limiting it. We're basically raising the compensation to the
Yeah.
the family. We're raising that compensation, but in terms of shouldn't we be raising the compensation of doctors so that they
Well, but that's
so we can
that's
get
not-
more
that's
so we can get a
that's
doctor?
a different issue. I think right now this helps us and helps hospitals and practices be fully staffed.
To get people.
Yeah.
Right, because we're assuming that there is just no doctor who wants to
Well, I
work
can-
in New Hampshire.
No, but I can tell you all the vacancies we have up at Memorial Hospital that lie vacant for forever because they can't find people.
Right.
So choice between a nurse practitioner and not seeing anybody, I'm going to go to nurse practitioner.
Right, right. No,
If I have a heart attack, or I'm going to go to the emergency room, or if I have something serious, that's another story.
No, I
But
hear you.
For a physical, they're perfectly qualified.
Right, but we are saying that we're basically dissing doctors by passing this bill.
I don't
because
believe
we're
that
saying
at
the
all.
doctor's degree doesn't matter.
No, it does
it's
not.
not, because it says you're not using it solely.
No, I
The
understand. this
hospital
one.
still
Yeah.
has the right, or the practice still
All
has the right.
things being equal. That's right. If everything else is being equal, right. So I hear you. it's just a little touchy, but other people have any feelings on this subject? Representative Purcelli?
Well, I do believe it.
Pull the mic close. Yeah.
I do believe that it does open the door for other specialties to make the same case. So between ophthalmologists and optometrists, or you could start naming all the different professions. I totally respect the hard work of the ARPN. Totally respect that work, but there is a difference in their training. And I think that needs to be recognized.
It's a good example, ophthalmologist.
I mean, I'm not saying that they are equal, but you could certainly start to make the case. You can make the case with social workers and we have a mental health crisis. So you can start saying, wait a minute, we want everybody to be paid the same rate. And that is, in my opinion, a disincentive for people to go on to, specialty or higher education, or put in the time and the work and the money required to get a different credentials. But I totally respect the hard work of these professionals and how they provide a service in areas that really need that type of professional.
Representative McHugh. Let the committee first.
It didn't seem like this bill does a whole lot to me.
Right.
It seemed like the contracts would just be negotiated somewhat differently, and potentially, like if a given payer or institution negotiates on level of licensure now, and we say, well, you can't do it just because of the letters after your name, maybe they'll start setting a minimum level of experience or number of patients, throughput, or just some other means, and then we'll have to step in and say, well, you can't pay solely based on how many years you've been practicing or what's next. So I'm not sure it'll have much effect. I don't have a strong position one way or the other on it because of that, because I'm not sure it'll make much of a difference. My one concern is, could it bring down the level of physician salaries and actually make that very obvious problem of physician shortage worse? And I don't know the answer, but what do you think?
I don't think that's the case. I mean, the market is the market rate. Doctors, when they're looking for a job, they're not only looking at the hospital, they're looking at the state. They know what they're supposed to be paid based on what other physicians are paid. So I don't not believe that. And for the people who testified, that 15% did make a difference. So you can choose not to go to an NP if you're not a nurse practitioner, if you're not comfortable with it. I go to a physician. I go to a physician in Maine, just because she does a really comprehensive exam. But that's, again, it's my choice.
Do you think we should include the other mid-levels, PAs?
No, we don't want
No.
to expand this anymore.
No, I don't think we should expand it. Yeah.
We don't.
Yeah.
We're talking about whether we want to do it
But,
at all.
nurse practitioners are really well trained, and, they're not going to do brain surgery. They're not going to, remove your appendix. They're trained to do certain things, and they do it as well as doctors.
But why not include there's plenty of orthosurgical and cardiothoracic PAs, plenty of them. In fact, every cardiothoracic suite and orthosurgical suite has a PA
Well,
in
then
it.
let's do another bill on that down the road.
I think we ought to give them parity if we're going to do it.
That scares me.
Okay.
That now you're reinforcing why I'm a little worried about passing this bill.
Okay.
Because they're going to the PAs are going to come in and say, look, you passed it for them. Why?
Probably.
That's not a reason not to pass this.
Probably.
Worrying about the
No, just
camel's nose under
deal-
the tent?
deal
How
with-
often have I heard that expression? Okay, Representative Raffner.
As I understand it, it's reimbursement for services that the NPs are providing that are essentially the same services that a doctor is providing. So what the bill is saying is they should be reimbursed at the same rate. And I think a point was made a minute ago that NPs can't do all of the things that doctors do or surgeons do. It's just the services that they provide that are essentially equivalent to what a doctor does. And, in the case of underserved areas like the North Country and, rural parts of the country, it's really difficult. There's such a shortage of MDs. And if nurse practitioners are providing the same quality of service and the same services, it seems reasonable. I don't think that means NPs are compensated the same in general as doctors, just for the services they're providing that are equivalent.
Representative Purcelli.
But this is part of a contract negotiation, correct? So I'm not sure why, the providers can't work with their representatives to have a better this is a individual contract, correct?
Right.
So I'm not sure
Well,
why
no,
we
no,
need to-
actually, this is,
Or
this
these
is
are
a contract
contracts.
between, to whatever the physician office
Right, and
and the insurance company.
okay, so why aren't they having the conversation to say, this is what I want to do? And I think Anthem already recognizes that.
And that's the reason why they're okay with this bill.
Correct. So, the other
therefore, we
insurance
should just be
companies
okay
should
with it?
follow suit without legislation.
Well, no, and they're saying is that, okay, that the request for this legislation obviously came in and they're saying, okay, here's what we can live on. And that, and when I heard the list, if I remember this correctly, that degrees are allowed. So that as much as we all agree that MDs have more degrees and have more experience than a nurse practitioner, I guess what this might come into is that the nurse practitioner has been around long enough to make up for the difference where that doctor had his what do they call it, when the residency. So would that be included as saying that that's making it equal? So in other words, what we're saying that the only way that that nurse practitioner is going to get the same as a doctor is that that nurse practitioner has been around a while.
Right, but, and it's highly subjective.
I think,
Well, yeah, it's has all those subjective categories. That's where the solely comes in. So I guess you just convinced me maybe that this is okay and this
yeah,
is
I think
harmless.
another,
This is harmless now because I guess it's true that if a nurse practitioner has been around a long time and has all the other credentials that an MD might have, they well,
I think there's another aspect. You were talking about a doctor's office negotiating with the insurance company, but a number of the nurse practitioners practice independently. And they don't have anybody that would speak for them to get the solely, the part of the negotiation. And so I think that they ought to be able to, if they have a decent practice, but there has to be limited, of course, to doing the things that they do that are the equivalent of what their doctor does. I mean, certainly not brain surgery or anything like that. And I don't think they would try to do something like that.
right.
So I think it would be
Are we-
okay.
Okay, so are we talking about just primary care, or are we talking about other things that nurse practitioners are technically qualified
The
for?
way the bill is currently drafted is just mentions licensure. So it is not specific to APRNs. It would be specific to any kind of licensure.
Well,
and
we
it's
have
not
that. We have
talking
that
about
amendment to
Okay,
change.
so if there's an amendment that's just for APRNs, then it'd be
Correct.
just APRNs, but we're not talking about services.
Right.
APRNs have a very broad scope of practice. As long as they're practicing within their scope, then that's what their reimbursement would be based off of. And I think it's difficult to say because I think you guys are all bringing up great points. There's a lot that goes into negotiation. Everyone that has a contract with an insurer, whether it's part of a practice that has a contract or an individual, they're negotiating those rates, and you have a fee schedule. So that fee schedule, I guess, is what you're talking about with services, that's what they've agreed they'll be reimbursed for, but there's other methods of reimbursement that are not necessarily a fee schedule. So I would just stay away from thinking of this as services because it's the contract that this legislation is talking about, that they can't, just because they're an APRN, have that 15% lower. And not all carriers do that either.
Anyways,
Yes.
okay. Okay. I mean, since we are going to amend it to have the amendment that is just just the nurse practitioners. I mean, I guess in the scheme of things that it's it would sure be nice to get some more physicians in my family my practice, but it's in this case it's the negotiating is actually the hospital who owns the practice, and the hospital, and they in the scheme of all those things they're negotiating with the insurance, and now we're negotiating the primary care physician. But yeah, Representative Walsh.
Thank you, Mr. Chairman. Since I'm not on the insurance committee, I just want to understand it for when it gets to executing it.
Right.
Does this mean that contractually, the ARNPs would get paid the same as a doctor?
If all things were being equal. Okay, so in other words, when the contracts are drawn up and how they value that person, is that they really do? They're specifically to that one person? Are they really to a person when it comes to, again,
All
I'm
contracts are negotiated differently. So I think the thought behind this bill was to the extent that there is an APRN practice that is just APRNs and there is no doctor, they cannot be compensated less than if there was a doctor in the practice. But that's hard to determine because, again, you're looking at a number of different factors. So if this APRN practice, if there was other factors that would justify compensating them less, then that would be the basis for adjusting the compensation. Likewise, if it's a rural practice and there's no one else in the neighborhood and they're the only shop in town, that would may be justification for reimbursing them higher than doctors. There's just a lot of different factors, and the way the contracting is done, it can be with an individual provider if they're a sole practitioner, it can be with a practice, it can be if it's a hospital owned practice, it could be part of a hospital contract. There's just a lot of different pieces to this. But in theory, that's how it would work. It's everything is equal, and it's just the only difference is one's an APRN and one's the doctor. It would require them to be compensated at the same level.
Representative Burrows.
I don't know if you know this, but I'm asking a question. Doctors in hospitals, because I live with one, I mean, it's very clear what their parameters are in terms of what they can and cannot do, particularly with specialties. And doctors frequently get in trouble for doing things that they're not authorized to do. So wouldn't it be the same for a nurse practitioner? They are given parameters to things that they are licensed to do, and other things they have to call in a doctor.
They have a very broad scope of practice. So if a hospital were to put in parameters about what an employee can do, that would be different. But under law, I mean, I'm not
But I think
PLC, but they have a very broad scope of practice.
I think a hospital can do that because they
Yes.
determine, you know, like we are in my hospital. He's gone, so I can say it. We had a who's a bone guy. What do they do? Orthopedist who did a heart procedure, and they canned him because what the heck? So, you know, hospitals do determine what can and can't be done depending on what your training is.
Yeah, so that would be part in the scope of your employment, not necessarily a law saying you couldn't do that, or an insurer. I mean, that gets more complex, because if you are hired and there's specific parameters based on your employment about what your scope is going to be within that set, then the carrier can use that as a basis for contract. It can say, you know, based on your scope of employment, you're going to do, and usually it's a list of services, and those are the types of services you're going to bill for, and this is what we're planning on reimbursing you for, and it's part of the negotiation. But there are so many different employment settings and different caveats to that. It's hard to be general about.
Should the bill be tightened up to specify that it's for comparable procedures, that equal pay for equal work?
Well, that's where
That
the
is
solely.
what makes it too complicated to
Too
enforce,
complicated, yeah.
because, you know, you may think a physical here is the exact same as a physical up at COAS, but, you know, there's different practice settings, there's
Oh, yeah.
different licensures.
Well, there's a
different-
difference
all
between
that
an
other
MD and a
things.
DO. The
Yes.
DO is supposed to be doing a longer.
So it depends on those things. You can't just say every physical is the same, and that's
No,
why
they're
there's
not. I
negotiated
mean,
rates for everything.
Yeah, I
so-
mean, my physician in Maine, for example, she spends like over an hour with me, ton of tests.
She's probably a DO.
No, she's not.
She's an MD.
She's an MD. She chose to do this kind of practice. And I don't want to use my doctor's name, but doctors in my hospital do physicals that they literally have a clipboard and ask questions, and you're done. 10 minutes. So,
yeah,
and they
so-
get paid the same as, you know, my doctor would in Maine.
Yeah, so there's CPT codes for the different procedures, and those would be the service codes. But depending on the type of setting you're in, the geographic area you're in, all of those things can justify different compensation. So I think trying to tie it to specific services adds a whole level of complexity that would be very difficult for us to enforce from the insurance department perspective.
So are you
And that's
neutral
kind
on
of
the
where
bill?
this bill had started,
great.
and we tried to get them away from services.
Yeah.
And say this was kind of the compromise language that everyone came up with, is basing it just, you can't have different compensation based solely on your licensure.
So
as an
are you neutral on the bill, or?
Yes, we're neutral.
Okay.
But this is something that we could actually try to enforce if we add in that level of services. There'd just be no way for us to enforce.
But what do you really feel about the bill?
Okay, Representative Herbert, you have a question?
I'm just trying to, my understanding of the testimony I heard was basically it applied 85% of whatever 100% is for the MD. Pretty simple. I mean, if for the RPNs, right? So does the are you saying the legislation doesn't actually do that?
So that 85% is what is allowed under Medicare, and that's kind of where this came up with. But every rate is negotiated differently. Every time you're entering into a contract, there's a whole negotiation process. So just because you're allowed to go down that 80 to that 85% doesn't mean it's actually happening, because there's a lot of other factors that will go into contract negotiations. So it would be up to the person negotiating the contract to, say why they should get more than that. And that's where the negotiation happens with the carrier.
So would you
Yeah,
say
now
that,
I'm
so,
confused.
I'm sorry, just on a clarification, just quickly. So it's already solely not based on license?
There's a huge array of factors that go into contract negotiation, and licensure level is one of the factors that they determine. Yes.
So the bill isn't as hard and fast as I thought I was hearing. So in other words, if you're RPN and you have a MD and he's 100%, whatever he gets, that's considered 100%. The legislation that I interpret is that this RPN that does similar work gets 85% of 100. Now, I don't know if that's going up or down, but it says 85 and there's 100. So I don't understand all the other variations that the bill does not
So that's
discuss.
currently what Medicare allows, is that the 100% goes to physician, but under Medicare, there is a set rate schedule. So every physician is going to get what that rate schedule is based on, there's some parameters for inflation and geographic areas, but there is a rate schedule. And then the APRN would get 85% of that rate schedule.
That's a Medicare
But that's
schedule.
Medicare.
But if there's
In
other,
commercial insurance, there is no rate schedule. So it comes down to contractually negotiated rates. And that's for the carrier and the provider to negotiate. So under Medicare rules, they're allowed to use the APRN licensure as one of the factors to consider in negotiation. And what this bill would do would say that cannot be the only basis for you varying that reimbursement. But there's still all of the other factors that they can consider in coming up with what they feel is appropriate reimbursement rates.
okay, that was my understanding of the bill. I thought it was pretty cut and dried. It's not quite cut and dried. Thank
No.
you. But what is cut and dried? We're having a systemic financial crisis in hospitals. Systemic. And anything that I think would cause costs to go down is probably going to be required. So I'm all for 85, but I'm not for all this. You sound like there's a lot of other negotiations going on.
It's
And
very complicated contractual
Yeah, well, it's-
negotiations. So
bankruptcy is not complicated once you go bankrupt. And a major provider in Mass just went bankrupt.
Okay, but this bill has nothing to do with
Nothing to do with that.
Medicaid, Medicare, it's, right, is that correct? So
Yes.
would this bill, going back full circle, will this bill, what will this materially change? There's still a contract negotiation. This would make sure that the credentialing rises up in the criteria, but there's all this other criteria that still could be used. So it doesn't necessarily mean automatically that there will be pay parity.
no.
So I'm not really quite sure what this, how materially this is going to change. So if an insurance company realizes in northern part of New Hampshire, I really need to find additional providers, I better pay them, they would have that flexibility with or without this bill, correct?
Yes.
But could this bill have unintended consequences?
I mean, I think you guys have talked about a lot of the potential unintended consequences. Financially speaking, I think, where we have shortages in providers, carriers need to make sure they have providers available. And that's probably one of the largest driving factors right now in contract negotiations. Down
But
the
they would
road,
do-
maybe it
but,
might not
yeah.
be.
So the insurance company would say, I need to adjust my rates if I want to have a thriving practice.
Yes. and
We
that's
have a running
currently what's
debate
done.
whether network
that's
debate whether
done.
network adequacy, which is what that is,
Yeah.
whether how well the insurance carrier, we've had problems in the North Country, as a matter of fact. I think at one point, I remember Harvard was having a problem with the North Country.
Yeah, I mean, from the New Hampshire Insurance Department perspective, we don't see that there is going to be a huge impact on premiums. There may be one-offs here and there where contracts may need to be adjusted slightly, but we don't anticipate that being a huge amount of contracts. So we estimated that it'd be a very minor, if any, fiscal impact.
But that actually, the question about Medicare, Medicaid, do they distinguish between a nurse practitioner and
Yes,
okay.
they allow the distinction,
they allow the distinction?
and there's set rights there too.
You
and I
don't think so,
that's
Susan?
key. So Medicaid,
Oh, so the state, the Medicaid is 100,
So. what
but
about
just
this
Medicare,
amendment?
Medicare is. All right, so I guess I'm at this point where I'm at. I think I'm okay with passing this bill on the rationale that we need to do everything we can to make sure that our primary physicians' offices have employees and have people. And that that the purpose of this bill is for nothing else, is that we are addressing the problem people have of that that they can't get a primary care physician, that there are that there seem to be so limited out there. And so the rationale in my mind now is we're doing this so that hopefully we can get more. And for all the nurses I've talked to, it's always amazing how many. And I'd asked them, well, why haven't you gone to that nurse practitioner? It's evidently as much as we would think this is great that you can be a nurse that can be a doctor, but that there not a lot of them want to do it. Not a lot of them want to get there. So if we can incentivize them to go that way, then that would be good for our constituents who need primary care positions. in
What about
their
this amendment? Are we? I mean,
Okay, well, I'm just going to say I'm now okay with the bill, and what I want to do is have this amendment brought up, and this is the amendment that clarifies that this bill is only for nurse practitioners. So when I get quizzed, when bills come in the future and say me too, I can now say to them, well, the reason we passed this is because we wanted to do something to ensure that there were enough primary care physicians / nurse practitioners out there to satisfy the market that is in need.
Okay.
Yes, Representative Raffner.
I'm going to recuse myself from this vote because my daughter is actually a nurse practitioner who does an awesome job, by the way.
do I need to recuse? My stepdaughter is about to be a
Oh,
nurse
come on.
practitioner. I mean, she's not one yet, though. Okay.
All right, John, it's just you and me.
Okay. All right. He's not there yet. All right. Okay, so sure I have the right sheet in front of me here. Okay. All right. 556, Representative Hunt, seconded by Representative.
Do you have to do the amendment first?
Yes, Spear.
Yeah, sure.
Okay, to pass on the amendment number is 1785H. Any discussion on the amendment? Okay, seeing none, all those in favor of the amendment, please raise your hand. 1, 2, 3, 4, 5, 6. Okay, now it's the motion is ought to pass as amended. Okay, who would like to make the motion? Representative Spear. How many have you done boroughs? Borough 2, and Spear's done
So
one
who's
so
doing
far.
this?
Okay,
Okay.
so we'll let you do it. And okay, accepted by Representative Hunt. Any discussion on the motion about to pass as amended? Seeing none, all those in favor, raise your hand. 2, 3, 4, 5. and
Oh,
one
that
ab-
was 5.
And one abstention. Okay,
5.
all right, insurance coverage into the treatment protecting from discrimination.
Is this a,
Um,
anti-abortion thing?
I have a comment on this one.
Okay, so I would like to interim study it, but yes, go ahead with your comment.
Well, one comment I have is the act is incorrect. It says IVF and it should be IUI, but that's another,
That's a good choice, that's right.
but that's another
for-
issue.
For another,
I struggled with this one because of medical necessity. It's cheap enough based on the fiscal note. It's cheap enough. But I struggled with the medical necessity. And then, Chairman, you very nicely gave us a list of all the mandates that you have put in place. And one of those mandates is coverage for contraceptive drugs and services, not a medical necessity. Medicaid pays for vasectomies, not a medical necessity. So the definition of medical necessity has been interpreted a little loosely in cases when we decide that that's what we're going to do. Getting past that, I have to say I'm for the bill. It's cheap and it does some good.
Better than nothing.
My comment on the bill, I agree with Kerry, but I think we can expect in the next couple of years, additional bills that will be much more expensive along the same lines. I think, in passing that, which I think we should, just keep that in mind.
Representative Burrows.
My question is, the bill talks about infertility, but are two women who want to have a child necessarily infertile? Is that the right word for it?
Well, actually, I took this thing out and I was reading it really carefully, and actually, it's not. It says, regardless of infertility. In the bill, it says regardless of infertility. So then, when I read it again, so that means a heterosexual couple, or actually, it means that a woman who wants to get pregnant, who's fertile, obviously, and she doesn't want to have sex. Okay, a woman wants to have a baby, not have sex. So she's gonna say is, but I got my good friend here down the street. He's willing to be a donor, so I don't have to put in all that thousands of dollars to get a donor.
But we're not paying, that bill doesn't include that, right?
Yes, this bill allows for this.
No, it doesn't include the getting the donor.
That
part.
doesn't include
just
the
includes the
donor is the
placement.
whole, as we heard, was a whole huge other expense.
Right.
And so the reason why this thing is only so cheap is that he then provides whatever they need
You can't get
and
more
then
basic.
put it in the baster. That's what this bill is paying for it. This bill is allowing for
So, all right.
in other words, so
Using
that's what
your
I did.
analogy.
Now we're just down to the $200, and come on, there's when at the end of the day, that if people are choosing not, that they could do it, but they're choosing not to do it. That's where medical necessity is coming into. Yes, medical necessity of having contraception, okay, was that getting control of the body, and that was clearly I agree with you. It pushed medical necessity, it pushed the envelope on it, but that the issue was the cost. And how many costs and how you're going forward, because in terms of a lifetime, contraceptive and getting these, the device. And so I agree with you with that interpretation. that was probably a little bit of a stretch, but that the politics at the time was that we did not want anybody to say that I couldn't get contraceptive because the terms of the cost, and that the monthly payments or whatever would cost to have contraception. In this case, what we're talking about is that this has nothing to do with the personal relationships of the people involved. Okay, so of the woman involved. And I would say that bothered me a little bit, that in the extra paragraph of the bill, they changed it from her to them. And I say, oh my God, are we really going to get into that here in Commerce? Do we in Commerce want to be into that discussion?
No, that part, no.
Okay, so that's when I started looking back and I realized that it says, regardless of infertility. The whole bill is regardless of infertility. It's not even about infertility at all.
I have to say, there's one reason why, and I didn't want to bring this up, but you're forcing it. What do we call it when a woman has sex against her will and not because she wants to? What do we call that?
Rape.
Right, and that's what we're promoting by not allowing this.
No.
I'm sorry. A woman has the right to not want to do physical sex. She has that right.
And she can, if she can go find a guy who's willing to make a donation
And
for,
they're
for
doing that.
$200, she can get pregnant.
No, you can't.
That's what
Did you
this
look at
bill
the numbers?
says. That's what this bill says.
No,
If you get done on the first time, but you get up to 6, so it could cost you $1,200.
no. If you don't have the procedure, the IUI procedure itself, your chances of getting pregnant are very low. They're already low to begin with, but
We're
they're
talking
very low.
about a fertile woman.
Even if she's fertile, what's the difference? You don't usually get pregnant on your first try, although some people do. Oh, lighten up.
I think we should. I think I just this. I don't know. I'm not ready for passing this bill. Thank you, Chris.
When we had that woman couple in there, and there's all this money they had to pay for the sperm, why don't they just go out and find somebody that they think is intelligent, athletic, good looking, and ask for?
About the sperm, it was about the actual procedure.
No, I know, but they could get that sperm and take it and go do the procedure. Absolutely.
But it's just for the procedure, not the sperm.
No, I understand that, but I'm just saying that they could have saved a ton of money by not having to go to a sperm bank and buying that sperm, and then use this procedure. Yes.
Representative Cole.
I just look at this bill and there's one part that nobody's talking about, and that's forcing an employer to give up to 18 days off for people to get
That
pregnant.
section's got to come out of the bill.
Yeah.
All
So
that
I have a
stuff.
problem with that.
All right,
Interim
so we're going to
study?
have to IS this thing because we got to fix it anyway.
That's correct. Works for me. Okay.
Yeah, and I think you have to get into the current century.
Anybody like to make the motion? I'd like to have a woman make this motion. Well, I need subcommittee. You don't mind? You'll make it for me? Thank you. Okay. Second by Representative Hunt. Okay. And the motion is interim study. Okay, any more discussion on the motion? See, all those in favor say aye. 1, 2, 3, 4, 5, 6. Great, thank you. Yeah. Okay.
I think a man should do it.
I can certainly write it for you. All right, okay, so why is this list wrong?
All right.
Right, okay. But you understand where I was coming from in terms of okay. Okay. Uh, Okay. Yeah?
What's 1:15 is listed on the time. Do we have to stick with that? Are we allowed to do that, Ted?
No.
We're not allowed to do that?
I had, you know, when I was scheduling this, I was saying, I wonder if this might happen. Well, I'm not sure we have all the amendments ready yet. We don't. Okay. Okay. Right, so we have to wait, we're waiting for amendments anyways. And so, okay. All right, so the subcommittee is adjourned. We'll reopen at 5:61. 15. We'll open up the subcommittee. So first one is 561 relative to prior authorizations for health care. 561. What did I do with this one? Where is it?
OTP.
I know, I'm just looking for it on my cheat sheet.
Line 19.
Really? Okay. All right. And there was no amendment, right? No amendment? What do we have? What do we have?
Did it need an amendment?
Okay.
Yes, I'll pass with them.
561?
I don't think so.
I don't know.
No.
Where's my department? Jen, is there an amendment for 561? The prior auth? No. Okay. All right. Who's here?
I'll move up to OTP.
Okay, just a second. Let me get my circles here. Ellie, Raptor. Yeah, no, I'm all set. I'm now doing the subcommittee because no clerk today. Okay. And oh, I see this. Now I see why I'm all screwed up. Okay. All right. So Representative McGee. Second by Representative Burrows. Moves ought to pass. Anybody have any problems with passing this bill? Okay. All those in favor, raise your hand. 1, 2, 3, 4, 5, 6. Okay.
Did you make the motion?
Representative McGee did. Okay, next up. 254. Okay. All right. So who would like to explain this amendment? Who's here in the department? Anybody in the department want to explain it, or? I guess I'm so stuck with it. Is that right? All right, good. Yes, 354. Okay. Must be Belgium. Okay. Good afternoon.
Good afternoon. For the record, I'm Michelle Heaton. I'm the Director of Life and Health at the New Hampshire Insurance Department. I did not draft this amendment, but I can help you walk through it.
Thank you.
This is for the bill relating to the copay accumulators, or the coupons or discounts that pharmaceutical companies may give to patients to help address their out-of-pocket cost, and whether those discounts should be counted towards the patient's total out-of-pocket max. So based off of feedback from the hearing, this amendment was drafted to narrow the scope of it. And I believe what this will do is allow the discounts to go towards the out-of-pocket max when those discounts are for drugs where there is no other alternative treatment option. So it would not count in the cases where there is a generic or biosimilar or some other maybe lower cost treatment.
Okay, so
available.
where's that in this bill?
That is paragraph 2.
Okay. Number 2.
Oh, and before we get
Okay.
there, this would be amending RSA 415-18FF. So this is applicable only to group plans, and those are employer-based plans.
Right, and I see that on the back here. That's the Roman numeral 5, the high deductible plan.
Yes, there is a carve out there for high deductible health plans because the way those plans work is you have to meet the deductible before the benefits kick in.
Right. Okay.
So I'd believe high level, that is
Okay.
the majority of what this does. But I can
Representative
answer
Spear,
your
did
question.
you have a question?
Yeah, there are, when we talked last time, we talked about tier 5. Now, there are drugs still covered by patents and exclusivity rights that are below tier 5. And this looks like it would be applicable to those drugs that may not be anywhere near as expensive as the tier 5 drugs. And we talked about only limiting it to tier 5. We also said that we were going to, it wouldn't be forever. That is, if another drug came along, then it would have to move over to that kind of drug. Or you know, if there's, once there becomes a competition, so there, none of that is in there. So,
It is if you look at so if we're looking at Roman numeral 2, which on the first page is lines 13 through 19. It says shall apply to any amounts paid for blah blah blah, except in the case of a covered prescription drug for which there's a generic alternative, biosimilar, or other covered alternative available.
but it doesn't have the tier 5 limitation.
Yes, well, tiering can be subjective. That's typically what you were describing is typically how tiering is done, but it's up to the plan to decide how many tiers and what drugs get into those tiers. So it can vary. It's not that all plans will have a 5th tier or that there's certain criteria for what gets on that 5th tier. So it's not linked to that because every formulary is going to be slightly different.
So we're just giving this carte blanche pretty much all over the place.
Well, not if
No,
there's other treatments available.
this, it has to be one of a kind. It has to be a medication that is one of a kind.
Where I'm having a problem,
Yeah.
you take something, there are drugs that are much less expensive than what I typically think of tier 5. And what we heard at the hearing, drugs for $300,000 a year, those kind of things, that are less expensive but have been able to hold on to exclusivity for a while through all kinds of mechanisms. Not some of them necessarily all that to be comfortable with. And I am very uncomfortable with allowing the kind of payments that would happen that would exclude other people who are using generics and using biosimilars from getting the same benefit.
Okay, so and this has been part of my confusion too because of the other bill 555, okay, which is that they're giving those incentives because there is something, another potential alternative that someone may be interested in. What we're trying to do in this amendment is only address those particular drugs that you could say coincidentally a really high price, could coincidentally many considered a
Could.
tier 5, but the end of the day they are so expensive that what the best we could do to try to identify that group of what we're trying to focus in on. The best we can do is that there is no alternative. There is no generic. There is no biosimilar. That we're just assuming that whatever that drug is, and that we heard about the hemophiliacs and the cystic fibrosis, okay? That those drugs, that there's only one drug.
But they are not the only types of drugs for which drug companies have been able to establish exclusivity. And that's where I have the problem. Exclusivity alone is not what we want to
Yes,
cover.
I hear you, but I would tell you that exclusivity is not the issue that we're trying to focus in on. That's where exclusivity issue, which was somewhat related to the other bill. In this bill, we're trying to address that that these drug companies know that they have a very unique drug. It's a very specialized drug, and they're charging an arm and a leg for it. They can get away with
Understand
it
that.
because it's special.
I understand that.
And so what we're saying is for those people who are, page 2, in a high deductible plan, not because they chose it, if they were in getting their own health insurance, but because their employer chose it for them,
Okay,
that we're going to say to them that yes, that this independent charity patient assistance program that these pharmaceutical companies have created, that you can take that money and not worry about any tax complication or any, getting a freebie or whatever, that it's okay to get that money and
okay,
use
so it has to
pay
be
the
through an
copay.
independent charity patient assistance program.
Exactly. So if you want to talk, what is the biggest governor in this bill? That's the governor is that the charity is willing to give it because of this drug. They're not just giving it. They don't give this charity assistance to anybody and everybody.
Right, okay.
Okay. They're only giving it to people who have an income. They meet the income requirements. B, but more importantly, is that the drug has an incredible high.
All right, how do we
copay.
find a copy
The
of this 70
cost.
FR 70623 and the 3112? Oh, wait a minute, I think I have a copy of that. I
Okay.
have a copy of everything.
Okay. You
All
work
right,
on that.
if
Is there
that's
anybody
what it
else have
then
any other
I'm okay with
questions?
it.
Just to clarify, the high deductible health plans are exempt from this because of IRS regulations.
IRS
So,
regulations, right. Right. That was the Irish thing. Okay. Great. Thank you. Did you want to say something, Rolly? You want to make a suggestion? All right, you have to come over to the microphone so we all can hear it.
Thank you, Mr. Chairman. Mike Rollo, American Cancer Society, Cancer Action Network. for
You
the
have to
record.
talk close to the mic.
Thank you, Mr. Chairman. For the record, Mike Rollo, American Cancer Society, Cancer Action Network. And we thank you for the opportunity, and we thank you for the amendment, and we would be in support of the amendment. Just wanted to make one suggestion that might make it a little clearer. In paragraph 2, line 18, where it says covered prescription drug for which there is a generic alternative, biosimilar, and other covered alternative available. Perhaps it might be a little clearer if it said covered prescription drug for which there is a lower cost generic alternative, biosimilar, or other covered alternative available.
So you're adding lower cost.
I don't
Right.
think so.
Yeah, no, that's an honorable to put it in, help clarify it, but in this case, we don't want anybody to think in this case, there
You
is
don't
no
want a
generic.
lower cost
No, the
alternative?
lower cost, it wouldn't kick in. In other words, if there was a lower cost, they probably wouldn't be doing the charitable contribution.
No. Okay. I thought it would make it clearer for you. I thought it
Yeah.
would be clearing up what Representative Spear was trying to address, but
Right.
if you don't think it would, then I will withdraw my suggestion.
It's an interesting suggestion, but I'm not sure.
But if it doesn't address it that way, then I'm just trying to help. But if it doesn't work that way, then I will
I
withdraw the
appre-
suggestion. And again, we would support the amendment and say thank you for bringing it forward.
There we go. Okay. Amendment number
That was fun.
1903 H. All right. Representative Hunt, second by Representative Burrows, moves on to pass on the amendment. Any discussion on the motion? Seeing none, all those in favor, please raise your hand. 2, 3, 4, 5. I just said, is there any more discussion? Okay.
The only question I have is the insurance outfits okay with this? Can they live with this or is this
Okay,
gonna?
we just had a representative from the insurance
That was
department.
the
Yes, they're
department.
okay with it. And I have been assured by the insurance companies that they think this is a very worthy.
Okay, then I'm
Endeavor.
fine with it.
Okay, vote 6-0. Okay, yeah, I'll make it. You want to bring the bill forward, or you want me to bring it forward?
You can bring it forward.
Okay. Okay, Representative Hunt, second by Representative Burrows. On to pass as amended. Is there any discussion on the motion? Okay. The motion cleared. All those in favor, please raise your hand. 1, 2, 3, 4, 5, 6. Motion carries. Okay. Okay. Where was it? Okay, next up is Senate Bill 555, pharmaceutical rebates. Okay. I'll just move things forward here. Representative. Okay. All right, Representative Hunt, second by Representative Burrows. And the motion is ought to pass on amendment number 1794. Okay. This is kind of bill I like. It repeals something. Okay, so as it turned out, as I trudged through 555, is that it did pass, and I've been meaning to look up how I voted, but I'm pretty sure I voted against it way back when. But I've been meaning to have Kristen look me up and see what I did on this, but. At any rate, in the wisdom of Senator Bradley, way back when, he sunsetted the legislation. And so you would think that would be the rest of the story, except obviously when it came time to decide what we're going to do with it, that they decided to renew it, and then of course the bill had a bunch of other things in there about how they were going to renew it. And which was obviously controversial because it was mandating that all companies had to participate, even though some of the insurance companies were not doing it. So at the end of the day, in terms of looking at the statute and looking at what it does in terms of how it handles these things, in fact that the marketplace is actually freewheeling in terms of how they do it. Some do it, some don't. Some, whatever they want to do, the terms and conditions they want to do it. This is not a place where we need to legislate that let them do what they want to do. However, in that legislation that we have just would delete by this amendment, there is some interesting information gathering parts to it. And I have gotten an agreement with the insurance department that they will put out a bulletin. I'm not sure, does everybody know what a bulletin is? I know we've gone across that bridge. Yeah, we did a bulletin last year, right? Okay. Okay. So a bulletin is the department is sending out a notice to all its licensees, in this case, the insurance companies, and telling them in implementation of a certain law or implementation of a certain policy, here are the expectations that they have. And so it's very clean in the sense that it's, the department and its members, and it doesn't require statutory, creation. And they have a comment period and people can respond, and there's plenty of opportunity for the licensees to work with it. But in the end of the day, it gets us where we want to be without having to pass legislation. It's not a rule. No, it's sort of outside of rulemaking. And having agreed to picking up that language, that the department said that they agree with this solution, which, as you might remember, they were not too crazy about the original bill. So I think we have a wonderful solution to this problem. Anybody in the audience feel differently? Speak now or forevermore hold your peace. Okay. So the motion, Hunt, second by Burrows, to pass on the amendment. Any discussion? Any discussion? Seeing none. All those in favor, raise your hand. 1, 2, 3. 1, 2, 4, 5, 6. Okay, motion carries. Representative Hunt, Representative Burrows. To pass as amended. Any discussion on the bill as amended? Seeing none. All those in favor, raise your hand. 1, 2, 3, 4, 5, 6. Motion carries. Okay. Last but not least, right? 557. And this was a straight not to pass. Yeah. Did you want to do this, Tim? Did you want to?
Happy to. Want to pass.
Okay. Representative McGue, second by Representative Burrows. Yeah, I forgot that you wanted to do some of this other one. I don't know, is there any of these other ones that you want to?
Yeah, when we get to exec, that's fine.
Okay, all right, we'll take that up. Okay, ought to pass. Any discussion on the motion of ought to pass? Seeing none. All those in favor, say aye. 1, 2, 3, 4, 5, 6. And we're done. All right. And we're done.